Hello, my friends and colleagues. It is Mike, and I'd love to share with you a few quick tips for assessing and treating sciatica and related entrapment of nerves that cross through the pelvis into the leg. Tip number one is to do away, if you can, with this dichotomy between true sciatica versus false sciatica. That is to say, this concept that it's either happening at the nerve root or it's the piriformis squeezing the sciatic nerve here at the sciatic notch of the pelvis. If that's your construct, you are likely to be blinded to certain key aspects of the condition, and if you're successful, you won't always know why. And so I don't think it's that useful. I think that we can have better models in this case. For example, when assessing sciatica and treating sciatica, I would focus your attention on the major branching points of the nervous system. This peripheral nervous system is really of one cloth with the dural sheath that covers the spinal cord. The two move in tandem so that, for example, when this leg kicks out into flexion, the spinal cord descends within the spinal canal by about ½ centimeter. That means that we've got one contiguous fabric which we are trying to assess for its mechanical health, its state of irritation. And if we focus on its branching points, we're likely to identify the key places where it might be compromised. So where are those branching points for the sciatic nerve? Well, first we are looking at the nerve roots L4 down to about S2. Okay? And we're looking for irritation, inflammatory process, fixation or guarding. We're looking for foraminal space. So if somebody goes into a lateral flexion or a compressive motion, is there a reproduction of symptoms? So that's a major branch point for the dura is right here at the nerve root, right? Another major branch point is here at the sciatic notch. So we're talking deep to the gluteus maximus, but superficial to most of the deep lateral rotators. This is where the sciatic nerve and friends begin to branch out into various parts of the glutes and the back of the leg. Lots of opportunities for entrapment and irritation here at the sciatic notch. Perhaps that's not news to you, but finding it within its layer and thinking of it as one fabric might be helpful. Going further down the leg, different people will have different configurations here, but most humans have a sciatic nerve with a lateral and medial component going down the middle of the thigh. And then here at the mid-thigh, if you were to ever press between the bellies of the hamstrings at the mid-thigh, you'll notice they are less easily separable about halfway down the thigh. And that's because that's where the hamstrings are innervated. So they're bunched together there because that's just where the sciatic nerve is going blick and sending projections into the muscle bellies. That site, if it's a site of old hamstring injury or fibrotic change, might be a site of entrapment for the sciatic nerve. And it could increase dural tension up the chain, etc. So we got the mid-thigh. Then let's go to the back of the knee. Now, most people will have a split of the common fibular division and the tibial division here a few inches above the knee, just where the hamstrings begin to spread out. The tibial or popliteal nerve will come right down the median part of the back of the knee, whereas the common fibular or common peroneal nerve will track just on the inside of the tendon of the biceps femoris, and then finally curl around the neck of the fibula here, right? So that branch point, right where the hamstrings begin to split, that's worth your attention. Another key branch point is here at the top of the calf. You will forgive the lack of actual calf muscles here. But the popliteal/tibial nerve begins to perforate into the soleus here at the top of the calf. That site of perforation is also a branching point, and some of that nerve becomes superficial and becomes the sural nerve, which takes contributions from common fibular and then flows over the top of the calf muscles, down onto the lateral aspect of the Achilles and then innervating the lateral heel and the little slip of the lateral foot. That's the sural nerve. And then deep to the soleus, but superficial to the deep compartment of the calf, you have this tibial nerve that runs deep and then begins to track medially until the tarsal tunnel and then the bottom of the foot. So major branch point, top of the calf. Another major point is this medial aspect of the ankle, the tarsal tunnel area, and where it begins to proliferate into the plantar fascia. It is no accident that plantar fasciitis tends to happen most commonly right where the tibial nerve perforates in. How about that? Likewise, for the common fibular nerve, as it curls around the neck of the fibula, you've got a deep component of that nerve that tracks just next to the interosseous membrane, deep in this anterior compartment. But you've also got superficial branches that flow down over the top of the foot. So these major branch points are worth your attention for both assessment and treatment. Try to stress it mechanically, palpate it, ask about symptoms in those areas, and you'll get a more complete picture of what's going on. The other tip, and the nice thing about it is it rhymes, when in doubt, treat from midline out. So I break this rule all the time, but if I'm dealing with complexity and I want to have a heuristic to fall back on, I will start here at midline, and I will see if I can get autonomic calm, I will see if I can get segmental ease, and I'll see if I can get breath and movement into the lumbar spine, into the pelvis, and then carry that freedom, carry that autonomic calm, carry that tonus change down the leg toward the foot. Why work in that order? Well, one reason is very simple. If you work in a stepwise progression, you're unlikely to miss things that you might have otherwise missed. Another good reason is that if slack in nerves is a feature of their mechanical health, that's to say, if a nerve needs to be able to slide within its container to get access to blood supply, then if you build up that slack at midline, then each next place that you're working will have that prior slack available to it, right? So you get things a little freer here at midline, and then when you're working at the sciatic notch, you've already got a well-supplied and somewhat slidable dura, making your job easier here. Likewise, as you go down the line, plenty of folks will have a different order of operations. They might work from the foot up, but for me, when in doubt, I work from midline out. If you're interested in this and other subjects, I teach classes on it, but otherwise, I welcome you to chime in with your own simple heuristics for working with sciatica. It's a condition that's been around with us for thousands of years. I don't imagine we'll be rid of it anytime soon, but a little bit of intentional and careful body work can take someone a long way. So, focus on major branching points, work from midline out, and know your anatomy. This will help you really ask key questions and release your intuition, the greatest expression of your style as a body worker. Thanks for listening, and hope to see you sometime soon. Bye.